All right, good afternoon, everyone. Folks are filing into our Zoom room today. Welcome, welcome. I am Bethany Hamilton with the National Center for Medical Legal Partnership. I want to thank you all for joining us today on session 4 of the Using Legal Services as part of our community strategy to improve maternal health through health centers. As you all know, for short, we just call this our Maternal Health and MLP Learning Collaborative. Today's date is March 22nd, 2023. And again, we are here in the final session of this year's cohort. This is the second year that we're convening the group. And I would encourage everyone to not treat this as a final session. Let's just hope we can all come back together again sometime next year or even sooner rather than later. All right, so let's go to the next slide. And I want to thank everyone for joining us again today. Please take a moment, especially since this is the final session for this cohort, to turn on your cameras. The folks that are presenting would greatly appreciate an opportunity, especially with this last chance to be gathered together. If you could make us feel a little bit more connected as a group by turning on your cameras. The speakers are spotlighted, but if you happen to need any assistance switching the view on your Zoom, if you hover over the screen to the top right on your Zoom platform, you should see the ability to change the view. So there's an icon that says view, you click on it and you can change the view to show gallery, and all of the speakers will still show up as they speak, as well as all of us as participants in this cohort. So please, it'd be great to see you. Don't worry, we've been seeing grandmas, grandpas, dogs, everyone for the last 3 years together. It's okay. It actually makes it feel more intimate as a group together. So welcome back, everyone. Again, you're joined on mute, but we encourage you, this is not a webinar, this is a learning collab, to unmute and chat, speak at any time, share comments and questions. You can also share your questions in the chat. If you do want to and need captions activated, just hover over your Zoom window so that it shows up as an option to activate the captions, select captions, and then show them. We are recording this learning collaborative, and we'll make sure that everyone receives access to the recording. And then again, send us your questions as well in the chat if you need any assistance. All right, let's go to the next slide. Again, this has been funded by HRSA, so we really want to thank the Health Resources and Services Administration for continuing to support our efforts here. Many of you work with more than FQHCs, especially through your work on maternal health. And so we just want to make sure we really acknowledge how much flexibility HRSA gives us to work with a diverse array of medical legal partnerships as they address some of the pressing issues for mothers, birthing people, and entire families in our healthcare systems. Let me continue to admit folks coming in. Let's go to the next slide as folks continue to join us. Remember, we are talking about using legal services, civil legal services, as a part of your community strategy to improve maternal health, looking at health centers and the role that primary care setting plays in this maternal health or perinatal health journey. This is the 4th of 4 sessions. We're going for about 90 minutes today. I will be quiet very soon so that I can pass the mic over to our subject matter experts who are joining us. We've gone through the overview and discussions of the MLP model, but as you hear from the Georgetown Health Justice Alliance team, feel free to ask them a little bit more about their model that they talked about in depth, especially on the first year of this learning collaborative. Let's go to the next slide. So today's agenda, I'm going through the introductions very quickly so that we can really dive into the presentations and hear from you through the discussions, and then we'll close out, not with the next session, but we'll let you know more about what's to come and encourage you to continue this work. Let's go to the next slide. Again, these were the objectives. Hopefully we are achieving them. We would ask you to please fill out those evaluation links that come or shared for each one of the sessions. They come up at the end of the slide decks with their own unique URL links to SurveyMonkey. We really, really appreciate having and receiving your feedback, even as we close out this particular year's cohort, because that's how we're able to integrate your feedback and make improvements and bring this back from year to year. So hopefully thus far we have achieved helping you better understand the role that MLPs play in maternal health, helping you detect and address unmet legal needs that negatively impact maternal health, and develop strategies or improve those strategies to collaborate across health and legal settings. Let's go to the next slide. All right, so we are at that bottom row of faculty here today. We are joined by, once again, because they joined us last year, Vicki Gerard with the Georgetown University Health Justice Alliance. Vicki Gerard is actually director and one of our great partners and friends to the National Center for Medical Legal Partnership. Vicki, thank you for all of your support. Also joined by her partners and colleagues, Dr. Laurel Patchen with MedStar Washington Hospital Center, and again, Roxy Richardson of the Georgetown University Health Justice Alliance, who runs the PLAW MLP project. Let's go to the next slide. Roxy, Vicki, Laurel, thank you so much again for joining us. Let's take a moment before we jump into session 4's content to just reflect upon session 3, where Nola Booth of Law New York in upstate New York presented on the rural MLP that she's starting up there. So this is our last chance to get to know each other if you hadn't done so already. But even if you have, let's do it again. Type your name, your title, your org in the chat, and please share one major takeaway from Nola's presentation during session 3 last week. So let's go ahead and take advantage of that in the chat. Take a moment to share in the chat your name, your organization, title, and a takeaway from session 3. As that's happening in the chat, again, we are on session 4, joined by the Georgetown University Health Justice Alliance team. Their bios, their full bios are in the welcome packet. If you need us to reshare that welcome packet again, just send an email to us in response to today's message, or yesterday's, excuse me, reminder message. And we will respond to share that full information, which included some resources. Georgetown team, before I pass it on to you, I just want to, since this is session 4, really thank the cohort participants for joining us. Maternal perinatal health, these are issues that we must address. There are a lot of pressing issues that we're facing and continue to face and tackle and as MLPs. And so I really want to thank you all for taking the time out of your very busy schedules as practitioners and developers of this innovation to address a specific issue head on. We hope, and I'll come back and say this again at the end, that you will continue to stay connected, exchange ideas about how we can continue to advance this work, and what else can we do to help meet your needs, including elevating your work at the national level with the policymakers, the funders, and stakeholders who are interested in supporting you. With that, Georgetown, thank you, and everyone for indulging me for just a moment. I'm passing the mic on to you. If we want to, Georgetown team, if you want us to, we can highlight some of the takeaways that were in the chat, but the mic is yours. And thank you, everyone.
Thank you. Thank you so much, Bethany, the National Center, all of you that have participated. And I'll start by saying really appreciate those of you that are putting your cameras on. I think when we actually do the little discussion sections in between what we're going to do, we'll take the slides down so we can see faces. It's our last time together. And maybe it's the first thing I want to say, which is Georgetown University Health Justice Alliance is what we refer to as an academic medical legal partnership. So I might be putting a little bit of my teacher hat on there by asking you to share your videos where you can, understanding things are different for everybody. So we've been really excited to be part of this last year. We think that the time that we had together during this session, we've learned so much, and appreciate all the other presenters as well. Really want to give you a chance because I think we are probably among maybe the most developed or the most advanced in terms of focusing in on maternal health in the work that we're doing. So we read your goals and aspirations for these sessions, and we want to really try and address as many of those as possible. So if we can go to the next slide, I just want to start by saying what we're going to do today is focus on 3 key areas. kind of the healthcare provider perspective, because we don't get to hear a lot from our healthcare providers in the medical legal partnership world. So we really appreciate Laurel being here with us. She will inspire you. Then we're going to really talk about kind of the boots on the ground, how our maternal health MLP operates, and that's thanks to Roxy Richardson, who will give you kind of the legal services and the nuts and bolts perspective. And then I'm going to finish up with some more of the logistics. I know some of you have really asked questions and are curious about kind of how did we start up, what's the research part of our work, how do we manage the funding, and so we can address some of those moving along. So I'm going to, if we go to the next slide, just give you a really brief introduction of kind of what the perinatal law assistance and well-being, we call it the Law Project. The genesis of that medical legal partnership was really Laurel getting connected to us through our very, very small law clinic work with community pediatrics, where Laurel was the nurse midwife in a school-based health center where we were seeing patients and doing a very academic MLP there, and just was really excited about having us join her. And she'll kind of tell you what motivated her and why she thinks this is so valuable. But we started doing a needs assessment in 2020. We launched our services in 2021. So we're just about 3 years into it at this point. But we've got 2 full-time lawyers who are working with the MLP. They're doing kind of all the traditional MLP work and services. And then we've also built into that a lot of research and evaluation because we think that that's so important. And again, we know that's one of the areas that some of you that are further along have been really interested in. So I'm going to actually just go ahead and pass it right on to Laurel, because I think starting with the inspiration, I always remember the National Center saying, you got to tell people the why. That was Kate Marple's big takeaway always. What's the why do we do this work? So Laurel, passing it to you, and the next slide.
Wonderful. Well, hello, everyone. I am super excited to be here because a lot of the work in maternal health on the clinical side these days can be pretty, just a lot to hold. The good thing is that many people are much more aware of the desperate challenges that we have in the maternity healthcare system in the United States. And yet, you know, it's a lot to work in the space and it's a lot to hold. And I think one of the reasons that it's a lot is that in clinical medicine, people tend to be very aware of the dynamics of poverty and how it impacts healthcare outcomes. It is taking far too long for the frontline healthcare providers and our systems to recognize that poverty is not the whole picture. It is part of the picture, but it is really the systems of oppression that are also deeply connected to poverty that are harming patients. And we need to start to lean in to find ways to be able to bring that into our care planning and being able to really go ahead and be comfortable with the fact that being responsive to the environment and the context of our patients is a very different process than writing a prescription, but they are equally important if we want to achieve good health outcomes. And there is nowhere that is more evident, in my opinion, than with maternal outcomes. It's been decades now that we've had very strong data that's been replicated and looking at different data sets in our country around how poor maternal health and maternal death and infant death is not entirely driven by income and education. You still get horrible outcomes irrespective of your income and education, depending on how you look. And, you know, people don't show up differently based on how much melanin they have in their skin. The outcome is different because of the way we make decisions around that individual. And so I think the exciting thing for me is that as a provider, when you look at that picture, a lot of times you're just flummoxed because it's like, well, how do I, after having spent years in this very specific clinical training, how do I do anything about that? And how do I do that in addition to all these other clinical things that I need to attend to? And how do I do it in what is often for prenatal care, a 10-minute, 5-minute visit? So the piece that gets me very excited and really motivated about medical legal partnerships is that, you know, MLPs are the solution. that providers and the rest of our healthcare systems desperately need. And this kind of forum is super exciting because this is part of how we help healthcare systems understand that they exist, that it is a significant part of how we heal and how we move forward, and that the real challenge is now how to get people together and also understand how to interact with one another. In starting an MLP, I can say, it's really important to take a toe in the water and take a temperature in terms of what is the local OB culture. The OB culture, for example, in DC is very different than West Virginia or Alabama, or even Boston, and sort of understanding what is the local OB awareness around the dynamics that I just described, and how deep is the recognition that there are legal needs that harm health. And once you understand where that conversation happens to be in the local OB environment, it becomes a lot easier to then understand how to support and ignite the conversation around the fact that it's really important to bring in a medical legal partnership to be able to effectively address that intersection around poverty, oppression, and whatever other sort of environmental factors that an individual is in. One of the things that's important, I think, about taking that temperature and kind of looking at how to approach that conversation, or if you're invited into the conversation, is just recognizing that the OB environment has a very particular relationship to attorneys and fears of attorneys, because obstetrics is one of the areas of highest liability in our country. And so, irrespective of who we are as people and how we feel about where we position ourselves in this world of tension that many times exists between healthcare and liability and legal dynamics, that obstetricians and obstetrics have a particular relationship to that. It's a particularly big deal in OB because even within the medical system, we are very high liability, but we're also a very low revenue specialty. And so that particular combination makes OB have an extra tension, if you will, or an extra potential reactivity to even having a conversation with an attorney. It becomes particularly important because as MLPs develop and partnerships with providers and attorneys through an MLP, progress, one of the things that inevitably happens is the need to have that conversation and have that conversation with respect to the needs of a client. And in general, obstetricians have a lot of learning that we need to do in terms of being brave enough to sort of do things and put things in writing around a legal need that is connected back to a healthcare condition. And I'm sure Roxy's going to talk a lot more about that. I think the ways that this has come up for me is often tied to employment and accommodations. And we just get really scared when it comes to putting something in writing and understanding that that's going to then ultimately be interpreted and seen through the lens of a legal structure. Another thing that is, I think, really important about developing this kind of partnership is that in the conversation and developing interest and sort of understanding the need is to not only think about outcomes in terms of how you might want to document and understand and talk about them from a legal perspective, but then also linking back into what is it that your OBs are talking about, and where do we feel like we need to make progress. And the two conditions that people really suffer from in this country, in addition to death, are things like preterm birth, low birth weight. Those are very high in this country. They are long-term problems, and they are the thing in obstetrics that we have been trying for decades to try to address. And I think many of us, I would certainly raise my hand to say, we're not going to solve either one of those problems through approving another medication. A medication is not going to resolve oppression. It's not going to fix preterm birth. It's not going to address low birth weight as an issue. And so being able to talk about outcomes that the partnership is willing to address if we can be brave enough to say we're also going to include and we're going to want to look at those kinds of outcomes that the OB community is concerned about and is already struggling around, I think that's a really prime opportunity to get people engaged and to make sure that folks start to talk and recognize that the partnership may be solving needs that aren't traditionally linked to healthcare, but that we know affect the healthcare conditions that people bring in, but that the partnership itself will also drive the changes that ultimately result in changes around obstetrical outcomes. Now, we're very, very early in our ability to support, that pathway that I just outlined with evidence. There's a few studies now that have started to look at housing and housing insecurity as being potentially linked through preterm birth, but we're still very early in the process. But I think that is less important than how we approach the conversation and how we engage people around what an MLP offers in the context of the challenges of the obstetrical world. It's also really important to make sure that whatever, metrics are that are followed and however the infrastructure is developed, is that there's a nice feedback loop to the medical team. Certainly people will want to know, like, how many referrals overall are being managed or given, and how are those addressed. But it's going to be more effective if we're able to be brave and explicitly embrace some of these other kinds of outcomes that are shared as goals that have more medical language around them. In terms of operationalizing this, I think it's really important to make sure that the OB environment understands that the referral needs to be made, by us in the OB setting, and we need to invest in making sure that it's a high quality referral. We've done that by using screening instruments that incorporate medical legal questions, and I'm sure Roxy will talk about some of that. And it's a good starting point, but there also needs to be a process by which, once you ask a question that sounds like it might be a legal need, that there's an individual who really understands the follow-up questions to ensure that there's an actual legal problem. The way it's often come up for us is that people may request or respond to a question around benefits in such a way as it seems like, well, maybe it's been denied. Well, if the benefits have been denied, then potentially that's a legal question and we can refer that on. But if the patient hasn't applied, then that's not a legal issue yet. And so we need to figure out how to be able to respond to that. We found it really important to make sure that we as a partnership also try to figure out how to give the medical side some tools and some resources to be able to respond to the question. In the example I just used, if it's a benefits question and no one's applied yet, we've really drawn on our MLP to help us figure out how do we respond to that issue as well, because no one in the office wants to be asking patients questions that we can't follow up on. And so I think when approaching offices and environments, thinking a little bit about the foundation and the base of the relationship in those ways, so that people understand that it's a partnership that, yes, involves this referral process and making sure that the individual gets connected to the medical legal team, but also that there's a broader commitment to making sure that once we start asking these questions, that we do have a plan and we have an understanding and some resources to be able to answer the question and support the individual, even if it's not quite yet a legal question. In terms of improving, over time, which is, I think, one of the things that there were some people I commented on initially around what we wanted to learn and take away from. I think it has been critical for our partnership that we've committed to meeting regularly, and just being able to look at things more than once, over and over again. That regular feedback around, how many referrals that we sent were actually legal issues, and if it wasn't an legal issue, what was the missing piece? And then going back and re-educating our team. I will say too on that, last year, when we did this, there was a lot of discussion around the use and the participation of social workers as part of this process and referrals. We did start there, but we actually pivoted away from it and found that it was more helpful to have someone with more specific training around the referral process and making that ascertainment about it being a legal need, because social workers are really just sort of trained to be responsive in other ways, but not necessarily to be able to bring a solution to a legal need. So we actually found that it was more helpful to bring in a different kind of specialist around that. So I'm going to pause there. I hope that wasn't too much. And, happy to take any questions if there are questions. And
yeah, I'm gonna pop in and just say, Reha, I don't know, if it's not too hard, can you take down the slides, stop sharing, and we could just have a little bit of a conversation here. That makes it a lot easier for us. Again,
nice.
my teacher hat on. Thank you. And I just want to say, while people are thinking of questions, I was thinking, Lauren, in your response, it's like, absolutely, providers need more time with patients. And one of my MLP dreams is that the lawyers on the team are going to help you all advocate for more time, because I think one of the things that has really been sticking with me lately, and we've seen this across our cancer project as well, is that trust is a social determinant of health, and you can't build trust without time. And you'll hear Roxy talk about her patient work, and it's the trust that she builds with them that makes the difference. And I think at some point that has to be a good thing for the healthcare system. So I'm right there with you. Nola, you had a question, go ahead.
So y'all know I'm out in rural upstate New York, and there are far too many folks who need prenatal appointments and far too few providers for those appointments. And I'm wondering what are some of the ways that you have made it clear to physicians or gotten physician buy-in to, from not just physicians, but providers, other healthcare workers, that it is worth their time to add additional questions, additional screeners, however you want to frame it, to that narrow window of time they have with a patient?
Oh, sure. That's a great question. Thank you for asking. So first of all, I wouldn't, we shouldn't be thinking about the asking those questions as a quote provider responsibility. We built it into triage. It's, asking the questions in a systematic way more than once during pregnancy is super important. And that doesn't have to be owned by a provider. We have our triage team do it. And, it's a collection of maybe 5 questions, and then we follow up on those. And Roxy's going to talk about why we have the questions we have in terms of a needs assessment, but we just built it in as part of, you're getting your blood pressure taken, we're asking you these questions, we're putting it in, et cetera. And even that initial response, like if someone says, one of our areas that we ask about consistently is food insecurity. And if the person reflects that they've got some food insecurity, then, already before the person even gets to the provider, the nurse is able to, say, okay, here's what we can do immediately, because we do have some resources for immediate. The second is, have you applied for WIC? And, if they don't, they need their letter, they take care of that. And then the third is, I'd like to see if potentially our medical legal partnership could help with this. And of course, patients also need to be educated about what does that mean when you say our medical legal partnership. And so the buy-in and the emphasis also includes some of that training around, we can't just say, oh, go talk to this attorney, because patients are afraid of attorneys too sometimes, right? So there's an explanation about that. And basically, in terms of the referral to the MLP, the individual kind of that's all they need to do. Someone from our team will call you to ask a few more questions, because potentially this referral could be helpful to you. This would be someone who represents your interests. So someone from our team will call, blah, blah, blah. And then when our team member, we call them a referral specialist, calls, one of the things that they explicitly do is ask permission to refer to the attorney and documents it in the chart. So there's sort of 2 contacts with the individual, which we thought we were kind of concerned about like, would that be too much? Would we lose people? But people are pretty responsive. And if they're not interested, they just say that they're not interested, and some people aren't ready yet. In terms of the providers, this is the moment. Providers are being held accountable for the impact of social determinants, even though we don't have the skill set to do much about them yet. And we barely are learning how to understand how to ask the questions. But there's been enough movement and there's enough knowledge that we're being held accountable for them. The American Academy of Family Practice is one of the areas that's got the best social determinant questions, right? So it's coming in and we're seeing it. It's an opportunity because we're feeling the pressure. We don't know how to solve these things. And of course we care, right? So the message to a provider is, you're hearing about this from your professional organizations. People are asking you to start to do stuff about this and ask questions. Once you ask the question, we can help you figure out what to do. The important piece, I think, for some settings, and this was true for us, is that we are maybe in general a little bit more ahead of the curve in terms of integrating social work into the medical process. And so what a lot of providers have gotten used to is, oh, it's a social need. Let me get it to the social worker. And of course, social workers can't resolve the benefits denial either. And so I think it's worth, in that buy-in time, speaking a little bit specifically to that in terms of how this is a skill set that can address that problem, even if you, because many people think, well, Laurel, we already had social workers. It didn't really help that much, right? But the buy-in is, I don't think it's that, I don't know. I think this is the opportunity. This is the moment for that buy-in. In terms of the training, like Roxy and Vicki and the group were really great about recording trainings and making them available online so that then people could access them when they wanted and sort of on demand. And that was really helpful. And all it takes is 2 providers to do 2 referrals and get a success, and then it starts. People start talking about how much better and how much easier it was.
Bethany, did you want to ask Lauren to say more?
Yes. So, yes. And thanks so much, Laurel. We have Lauren Mutri also in the chat. So, Lauren, before you dive in, do you mind reading, in case folks can't see it, what you put in the chat? And then wondering if you wouldn't mind saying a little bit more about that.
Yeah.
Thanks,
I just wrote from the clinician perspective, for us and our patients, it's worth adding these additional screeners and triages if you have actionable medicine, and I include law in medicine, as opposed to what I call empty screeners or empty screens that just collect data and check boxes and take time. And if anything comes of it, often, you know, either it's data or our patients are referred to yet another line to wait in for help that often does not materialize. And these folks can't wait in line for weeks or months. And so it disempowers and it builds distrust in our patients. And I think also, on the clinician side too, like, oh, here's something else that's, you know, not going to work. So if you can make that medicine visibly actionable in a timely manner, and then feed it back to everyone with the consent of our patients and our families, boom, you start to build trust.
Sure. Yeah, and I really appreciate sort of you highlighting like that tension between people who want to ask data questions just for the data versus things that you can do something about. And I've dealt with that a fair amount. Like there are a lot of folks who are you know, medical scholars, and they really want to ask the questions. And we were very intentional about making sure that any question we asked, we felt was tied to something we could do something about. And I will say that one of the challenges with that is that then you're not going to ask a question about something that some people are going to think is important. And it's important because it also has an impact on the patient and potentially their outcome, but it's not one that you're in a position to do something about. And that is a big challenge. It's a huge challenge. And again, right, when Roxy talks about our needs assessment and sort of how we, narrowed and honed in on some of these pathways that we felt were most important during this particular period, that was a part of it. Just ask questions of patients that you're not going to follow up on and that you don't have a plan to do something about.
Bethany?
Yeah, I'll just be really quick because I want to make sure this is about the Georgetown team and the cohort. But I think it's for those who are newer to medical legal partnership or having these conversations with healthcare providers that might be in a position where they're even negotiating with some of these third-party referral platforms, right, that are asking for all of the data to be collected. It is important to remind folks that medical legal partnership is a flexible approach, right? And so the decision by the Georgetown team for the P-Law MLP is to make sure that those screening questions are designed to match up with actual services that can be provided. That's the choice that they made. Some folks can be even more restrictive, and then others may choose to design their MLP so that they are, in fact, if they're capable of doing so or have justified the reason for doing so, collecting all of the potential social needs, and then they're working on specific subsets of, for a certain period of time, subset of services to meet some part of those needs. So just remember the MLP approach is flexible, and this team has chosen to, for their approach, do it this way.
Yeah, and I think it's great. We pull up the slides back up and let Roxy take over. And as we're doing that, I will just say, I do think from our perspective, and we've now had 3 MLPs that we've started, that if you just go in with the iHelp screener, like this is our tool, you're going to quickly be overwhelmed with the number of legal issues and everything else. So I think a really good example of what Bethany just said is we generally don't screen for immigration because we don't have that expertise on our team. If it comes up, then Roxy and people in the other MLPs will try to make warm handoff referrals. But like Roxy will explain why we very intentionally ended up starting with a particular legal area, because you don't want to over promise and under deliver with medical providers at the beginning. Thank you. Reha, do you want to bring up whatever number we're on there? I think it's slide number 13 for Roxy. Thanks. It's all you, Rox.
Yes, thank you, Vicki. Yes, that is a perfect segue because as Laurel mentioned, knowing what it is that patients and also providers need. Part of the needs assessment that was done in the fall of 2020 asked both the providers, what were their concerns? And we got a lot of provider burnout because there were so many issues that patients were coming to them with that they could not address. And that was the perfect but let me tell you about the medical legal partnership model that can actually come in and help you resolve some of that burnout that you're feeling, that the work that you're doing can extend beyond the hospital doors, can extend beyond that exam room. And so providers and patients were both asked what they thought were their biggest stressors or what they thought were their biggest needs. And again, I know we talked about in the previous session about not calling it a legal need. I always say this, you don't know what you don't know. Folks do not know, if you're not in this legal sphere, that the issue that they're facing may have a legal remedy to it. So we ask it in a way that we ask these questions in a way that makes them like their social needs. And so from the needs assessment that was done in fall, these are the legal needs, or these are the social needs that the patients at WIS told us were their major concerns. So as you'll see in work, it was accommodations that came up, parental leave discrimination, FMLA, Family Medical Leave Act, the short-term and long-term disability leave. We had a lot of housing conditions, accessibility, evictions, family, we've got public benefits, child support, DV, IPV, paternity and custody. And so you'll realize and recognize that this is around the pandemic. And so employment came up quite a lot, right? So eviction was maybe not as big of a concern because we had that moratorium, So folks really weren't worried about evictions, but working they were, because so many of the businesses shut down. This is in the DC area. So a lot of the patients that are at WIS are hourly workers. They're not salaried. They are in the fast food or the service industry. And so with things being shut down, they were losing their jobs left and right. So this became a major concern for them. And as a provider like Laurel, how do you address that? There's nothing that they could have helped them do on their own. Yes, I can write you a leave accommodation, but if then your employer turns around and fires you because, well, I can give you all the leave you want and it can be a permanent leave, there's no legal consequence to that because they don't know their rights. And so we decided early on that was what we were going to focus on first, was going to be employment, again, to meet our patients where they're at, to meet the providers, what they're addressing or what they're acknowledging, and letting us know what the major needs of the patients are. That's how we chose, and that's how I chose to start the practice of providing legal services. We've talked about, like flexibility. It is a very flexible thing right now. The major thing, because the moratorium is up, and also DC had the emergency rental assistance program and they ran out of money early. So now the shift has been housing. So we're seeing a lot of housing cases coming in. And so again, we are pivoting at all times, trying to meet the needs of the patients and addressing these concerns that the providers are telling us their patients have. And so Laurel also mentioned, we have these training videos. So once we recognize and once we're seeing these referrals coming in, it's like, okay, we're seeing a lot of housing. Let's go ahead and create a training video for the providers that discusses these issues, these housing issues that they may come across. Or for the patients, there is a service that I will talk about a little bit more that Laurel at the WIS team has, which is called Baby Scripts. So it's a program that actually shoots out text and email blasts to remind them of appointments, to remind them of support groups that they can join. And we've actually been integrated into that service. So we will now shoot out monthly blasts about know your rights, things for patients to also, that autonomy, that advocating for yourself, things for them to pick up on, and then of course bring that back to their provider if they realize after reading through that, hey, my landlord actually didn't fix this issue. If it's mold, didn't fix this issue within 7 days. So I should be able to, I do have a legal right to X, Y, and Z. Let me call my provider back and see if I can get connected to PLAW to provide those services. And so, Reha, if you could go to the next slide, I'll talk about what that looks like, the referral process. So the patient referral process to us looks like we provide the trainings, like I said beforehand. So all of the issues that all the legal priority areas that we practice in, we made sure that the providers and the referral specialists were trained in them or received a quick little video. Again, we are at all times trying to meet both the patients and providers where they are. We know they don't have a lot of time. They don't have a lot of time when they're meeting with patients, and they certainly don't want to use up their lunch break to watch a 15, 30-minute video. So we like to do these bite-sized training videos for them to watch, and it will be, again, like those priority practice areas that you saw in that previous slide. And so once they get screened initially, again, it's integrated into the screening guide that gets done at the new OB patient appointment at their 28 weeks of gestational diabetes check screener, because that's when now women are or the birthing people are showing a little bit more. And so these employment issues sometimes come up, and then at their postpartum appointment. So at all times, there's some checks in place to make sure that folks are being heard. And so once these questions are asked part of the screening, we receive the referral from the healthcare team / the referral specialist. They confirm that the patient is interested in speaking to us. We then have our legal assistant who will contact them, confirm once again that they are interested in our services. You work with me long enough, I always say that the patient is the driver. So at all times, they're free to hop on out So we always want to make sure that they are comfortable and they are ready to pursue and to continue with this. So what we do is like I said, so we receive the referral. Our legal assistant will contact the patient, confirm that they want to have help, and we will provide services to them. That could be anything from brief advice, that could be anything from brief service to full representation. Sometimes there are matters that we're not able to handle in-house. So you'll see that other arrow pointing down to will provide a referral, a warm handoff. So we also, because as Vicky mentioned, we do not do immigration, we do not do criminal, and also if we're at capacity, because for a brief period of time, it was just me. I was a one-woman show, so I could not take on all the cases. And so we have established relationships with other community legal service providers in the DC community, Maryland community, Virginia community, to be able to provide these handoffs to, so folks, the patients didn't feel like we were just ping-ponging them around, because then folks lose that sense of trust. They just feel like you're just sending me off to somebody else who either doesn't care. Why can't this service happen with you? So then so this loop, so after we do that, we will provide feedback back to both the referring provider and the referral specialist. So that feedback is, I mean, just, of course, because of privacy, we'll say something like, we've accepted the case. The case is closed because the patient refused services at this time. The patient resolved the issue by the time we were able to call them back. The legal matter has been resolved, or we, accomplished the goals that the patient had. And so the referral is now closed. We do not stop that. Like, so if a patient comes back, so let's say that they no-showed at a couple of appointments and we didn't hear anything, they will also hear back from that. Like, the provider will also hear like, hey, we were unable to connect with this person. And so we do have 3 tries. And so we will just, we'll call 3 times, we'll text, we'll email, and then if we don't hear anything, then we will go ahead and let them know.
Roxy, how are you communicating that to the provider specifically?
Yeah, so we have so just via email back. So we have a referral form that the referral specialist at MedStar, who's fantastic, there's a form that they put like the name of the referring provider and their email address. So we have that contact information for them. So once we get that information and we're at the point where we're ready to provide feedback, we will go ahead and email the provider back that information and let them know exactly what next steps or what final steps were taken on that case. And so then what else do I have? Oh yeah. So that's the feedback loop that we provide to the patients, for the patients to the provider, so they understand also what happened and what, no, they do not. They don't fuss about email or fax. We also realize that, I think this is also really important, because I heard Lauren, you talk about like just the time, right? And so we realized that, again, this is going back to the flexibility as well. Our patients, the clients, are in this appointment for X amount of time. And some of them are coming from, either work or they have other children. And so the idea of us saying, okay, we're going to set up shop at the hospital, which is initially what we thought. I come from a pediatric MLP where I was also stationed at the hospital. But because that setup was a little bit different, I was dealing with only sick kiddos. Their appointment times are very long. Some of them were in transfusion and infusion. And so I could sit with them for 2 hours. That's not the case here. And so we realized quickly and early on that patients would prefer, this is a younger-ish crowd, where they would prefer to talk either via Zoom, text, email, calls. Providers, it's the same way. Email, they're able to, if they need to, forward it to the EHR versus fax. We also try to be green, so friendly. So making it an easier way for them to be able to copy and paste things into things versus receiving a fax, scanning it, and then trying to put it back into the patient's chart. So again, it became very, very clear how flexible we had to be in order to meet the needs of both the providers and the patients, because I think that also contributed to the provider buy-in, where they didn't feel like it was so many extra steps that they had to take in order for this to work. Again, we launched this during the pandemic where provider burnout was so high. And so the idea of trying to ask a provider to do even more would not have worked. And we would have definitely lost out on that, on being able, that partnership and that trust. I do see some questions coming in as well. And then, yeah.
I was gonna say, did you want us to take the slides down? When you're ready to take the slides down and just have a discussion, feel free. Just
okay. I was gonna go ahead and skip over to the resources so that you could see exactly what that screening chart looks like. So the screening chart, as Laurel mentioned, their health screening questions are always asked. And we've integrated some specific legal questions to be able to flag. So if a patient flags positive for a legal, it'll trigger that. So that is on, Reha, that's slide 18, if you wouldn't mind starting on slide 18, so I can show that, what that slide looks like, because it is our screening chart. And so because we have a referral specialist, so our team consists of 2 full-time staff attorneys, as Vicki mentioned. We have a legal assistant. We have a referral specialist that works with WIS, that is a MedStar employee, though, that helps with our referrals. And then we have rotating externs, student externs and interns throughout the semester. But as you can see, on the far left side is the WIS screening questions. So those questions have been plucked directly from the screening questionnaire that Laurel and her team asked the patients at their appointments. We took that as the social question, and then these additional questions that we ask the referral specialists and also for the providers to be aware of is what pulls into but is it a legal issue though? And so once they can answer affirmatively, or depending on what the answer is, then we seek that referral. And so the next few slides are just how in depth we've gone with how many, what the questions are that we're asking folks. And we just make sure that we've captured all of the areas. And even for those that we don't do, for example, we don't handle IPV or DV necessarily in-house. So questions like that, like immigration and criminal law, again, we still take those referrals because, as Vicki and Laurel have heard me say countless numbers of times, that our cases grow arms and legs. So just because somebody believes their main issue is a immigration issue, but it could turn out that they are an LPR, a legal permanent resident, and so they are entitled to public benefits. But because they're focused on, and they think that their main issue is, well, I need to, become a naturalized citizen, but they have a food insecurity. Well, we can maybe help you with that SNAP application, and so we always take every single referral that comes in to just ask them a few follow-up questions to see if there's an additional arm or leg, and if also they want us to help them with that issue. So, it's very intense, it looks like, but again, it helps us get those super great referrals that come in, and so allows us to kind of hit the ground running when they are connected to us, knowing exactly what they deem their issue to be and how we can already start thinking through how we want to assist them.
If I can, Roxy, I just wanted to say, this was a piece that Roxy brought to the table when we started that frankly scared me a little, because I was like, oh my gosh, what are we going to be sending to Roxy? What is this going to look like? And it proved to be super helpful because it helped providers sort of know, well, if it feels like a legal issue, even if it's not one of those screening questions, I still have a route, I still have a pathway. And so people were much more willing to lean in and sort of learn the process, because it wasn't like they had to figure out, well, what can I or can't I send? Roxy was willing to put her arms around it all. And I think that really facilitated the start.
Thank you. And then, so I mentioned Baby Scripts, which is that service that WIS and MedStar, they shoot out blasts to the patients to let them know about, again, support groups and services. And so, like I said, we've integrated ourselves in there because we want the patients to have autonomy. We want folks to be better advocates. Again, Vicki and Laurel have heard me say this, and I think Bethany as well, that I would love to live in a world where folks don't need us, right? That would be the dream. Unfortunately, that's not the case. But if we can help folks at least take that first step or feel so confident that, oh, I've helped, like, oh, I know this is a wrong. I know that my landlord is supposed to X, or I know that my employer can't talk to me that way. I'm going to reach out to my provider because I know that they can connect me to a legal service and it's not something that I have to deal with alone. We'll consider that a win. And so this next bit, so the next couple of slides are the flyers that we actually send out monthly. And so they have different areas. So, and concerns for patients, right? So we have the tax flyer that went out right before or right when the W-2 should have been out, to let folks know about the tax clinics, the free tax clinics that were happening around the DC area. Again, we do not do tax services, but we still, because we are partnered with these local community service and legal service organizations, want to make sure that folks are aware of that. The next slide is mold. So DC law requires a landlord to remove mold, but show of hands, how many people actually think that a DC landlord is removing the mold after receiving a notice of the issue? Well, patients are coming in saying they have mold, they've told their landlord, but they told them verbally, right? Like, but if it's in writing, then and you have pictures, and they are obligated by statute, by code, to remove it. And so this helps build a better case. And so because the patients that come to us in our client population, they are those who are being seen at MedStar, we can't take their neighbor unless their neighbor is also a patient, but they can tell their neighbor this information. Hey, I know a great, like, I've been partnered with this organization and they told me this, so you should look into this. And that's what happens. And we love to hear that. And so that's kind of, again, we want to empower everybody to be able to take these steps to be better advocate for themselves. And we can start that with the patients that we currently see. So it's like that trickle effect. And then the last slide is SNAP. So SNAP emergency, the pandemic benefits ended February 2023. So there were folks who were depending on those benefits, to support their families. But we wanted folks to know beforehand that, hey, your benefits may be reduced. And for some who rely so heavily on public assistance, and I believe the WISP patient population, at least from, was it 2021? It was like 90%, 91% were receiving some sort of public benefit or public assistance. So this was a big chunk. All basically of the WISP patients were, would have been impacted by this. And so we wanted to make sure folks knew this. So again, having public benefits is not a legal issue, but it can become a legal issue when now you're spending more money on SNAP benefits or on food benefits or trying to provide for your family. And now you can no longer make your rental payments, right? Or now you can no longer afford to pay your utility bill because you're having to spend more money outside for food. So yes, so those are some of the extra tools, techniques that we've pulled in. I see, I'm gonna leave time now for a question. I see that Henry asked a question about how much case fact information is in the referral. And it is not that much. It is very, very, very general. And so I'll drop exactly what it is that we put in into the chat so you can see what that looks like. But it is just, let me send it in. So case is open, ongoing with legal counsel. We do not provide fact-specific information. Again, because the referral also does say what the case is. And if the provider needed to go back to the EHR or the electronic health care record to see exactly what the note was that led to the referral, they can. But for purposes of information sharing, it is very general, and it just allows the provider to know the end result. And so if there's something that they need to do, for example, we've got some that the number or the email was incorrect, they will maybe send a new email. And so yeah, so that's my little spiel about how we've integrated into the practice.
Roxy,
yeah,
really quick question before you shift gears. What you pasted into the chat with regard to the referral feedback, those are standardized, I imagine, so that you can keep track at the aggregate level. You know, what's trending, what do people, how are cases being closed when you look at all of your patient data set?
Yeah.
Okay.
Yeah. So that goes both into, we use Legal Server as our case data management software or system. And so those are also fields in there as well. So we know, okay, like out of all those cases, this is, you know, how many refused assistance at the time, but we also provide that again to close the loop with the provider, just to let them know, hey, this is maybe somebody who was not ready. So maybe they need additional coaxing, but also if they do come back, right? We say at this time, we never close it permanently. So if somebody at their new OB appointment, so they came in to confirm pregnancy, has these issues, but they were not ready to address it, maybe it was a DV or IPV case, it's always at this time or at that time. Because then if they come back, you know, at their 16, 20-week appointment, and now the issue has become worse, the provider is always able to just refer that case right back over to us. And, you know, we'll ask the same questions if they're ready to pursue. Yeah. Are there any questions before I turn it over to Vicky for logistics that I might have missed about integrating the legal services part into healthcare practice?
And actually, I mean, while people are still thinking, I actually think I'm just not going to even go back to the slides because I don't know that they're really all that helpful for the information that I need to provide. I think the biggest issue is that, again, coming from the academic perspective, there may be some things that were unique to us in terms of startup, but I've tried to think about more generally kind of the lessons learned that could be relevant if you're just starting out or if you're really pretty far along. And I think to me, having just listened to Roxy, one of the most remarkable things about the MLP model and the success that we've had with ours is that our lawyers, if they aren't generalists when they start with us, they are willing to become generalists because so much of legal aid and services is siloed into, I do public benefits, I do advanced healthcare planning, I do DV, that kinds of thing. And Roxy and her team have just been incredibly supportive of each other. I think having more than one attorney on the team obviously makes a difference. One of the ways that we've been able to manage that, I think, is that we've adopted the law clinic model of case rounds so that all the lawyers across our MLPs meet and talk about their cases and share their expertise so that even people who don't necessarily feel like they're super confident in housing, they have access to those resources. And then we've been really good about making sure that people participate in whatever, like DC Bar, pro bonos, they provide trainings around like how to do this, how to do that. So that's one thing to think about. I think NOLA is probably another really great example of Equal Justice Works can give you ways to increase your capacity because you can have these fairly new law graduates with specific projects. And so, for example, in our cancer law project, that's how we built in the advanced healthcare planning expertise, is with 2 years with an Equal Justice Works fellow who really did nothing but focus on, you know, what does that look like for patients? And it applies equally as well to perinatal patients. Although, as Laurel reminded us, please don't come and talk to my patients about advanced healthcare planning when they're pregnant because everyone is going to freak out. even though we know as lawyers, everyone should have a plan. But anyway, that's a little bit dicier. But again, another one of those things you learn in the model. So I do think that that's a really, I really think that's a kind of a neat, a good perspective to embrace if you have that luxury. And I recognize that it is a luxury to a certain extent. The other thing I will say on the startup, especially for you that are just starting out, is if there is any way that you can set the expectations and the funding, it takes more than a year to get this started. Again, we were able to use some of our academic resources to do a lot of the needs assessment work before Roxy showed up. So we did that almost for a full year, talking to the providers, you know, understanding the community and things like that. Because it's just a slow process. And even when Roxy first started, we were kind of trying to we were grappling with her concerns about what kinds of patients to take, what kinds of cases. And I think Laurel really helped us identify the need to have some quick wins to get the provider buy-in, which is one of the reasons they also went to employment, because I think it accomplished Roxy didn't take too long to do those cases. And they were also really good examples for the providers of, this is how you're contributing to the MLP. Like, I need your expertise to write this letter for an accommodation. And so I think the other takeaway from kind of logistics is, to the extent you can keep your learning bi-directional between providers and the lawyers and providers, it feels more like a partnership. Because I think a lot of MLP healthcare providers come in thinking like, oh, I'm going to have the lawyers here and then they're just going to do that all. But we need them a lot more than we think that we do. I think the other thing is, and I'll touch on research and funding quickly, and then you guys can just ask any of us questions about stuff that's come up today. So research, Ellen Lawton, Bethany's predecessor at the National Center, told me it will slow you down in the beginning and it will speed you up in the end. And so I took that to heart. It's really hard to get the money to dedicate to the research. If you don't have any research funding or any resources, then the best thing I can recommend, and we've done this in our legal server where we track our cases, is just collect data on everything. Because you're not sure how you'll be able to use it or what will count. But I know when we started with the law clinic, which was our only MLP, we were literally counting, like, this is the number of times we met with a client. You know, these are the administrative calls that we made. These are the letters that we drafted, because it just helped us get a sense of what we could project moving forward. If you don't have any resources, but you have an academic institution anywhere near or affiliated with you, graduate student projects, I mean, like, again, taking the time to make those connections with people who are maybe interested in doing some of your research and would love to have access to some of the information that you're collecting is one way to think about it. But then mostly, I think we just really build it in wherever we possibly can to any grant or any situation. We're in the hospital. Laurel's been super supportive of the research. I think part of that, Laurel, is the academic center, which is part of MedStar Health, is also really committed to the research and sees that as a deliverable. So it's a little bit easier to say, okay, we're going to protect some time to do that. But we know there's not a lot of data out there, and there's not a lot of written about how MLPs are operating. And so we're trying to, on the academic side, increase that as much as possible. But I know it's difficult. And then on the last thing I will just say on funding is, and another well-learned lesson from the National Center, to the extent your healthcare provider has skin in the game, it's just going to be such a better partnership. And that can include in-kind and protected time, but financially, it really does make a difference. We've learned over time in our MLPs, it's not as hard as I thought it was going to be to get funding for the legal services. And we may just be lucky in DC. We have the DC Bar Foundation that's been super supportive. funders who are interested in social determinants of health kind of get the idea of like, oh, well, it costs money to have a lawyer and deliver those kinds of services. It's a lot harder to get money for the research. And it's a lot harder to get money for anything that we try to do around the educational piece with students, because I mean, technically the people feel like that should be tuition funded. But we know it takes a lot of oversight and it's a super intensive experience. So if you can kind of get around that, that can be super helpful. So I don't think there's anything. Oh yeah, one last thing which may impact some of you, formal agreements. So my strategy, and we're with MedStar Health, not a small academic health system. They're not even a center anymore. They're a system, they've told me. I kind of flew under the radar when we first started. So we had these amazing champions like Laurel and the people that we started our cancer law project with. And so we kind of started doing the work. And then my goal was to be like the banks. I wanted to get too big to fail. So when I did pop up on legal counsel or general counsel's radar at MedStar, there was a moment where it was like, you're doing what? We have actually worked our way through that, and we are now formally navigating an MOU with MedStar, which again is not an easy process, but happy to talk about, you know, tips for how we manage that. I will say one of our MLPs ran into trouble with a healthcare provider because we ran around talking about the fact that we were integrated and we were part of the healthcare team, and that provider assumed that meant we were part of the healthcare team and wanted to include us in patient huddles before we had permission from patients, and we ran into a HIPAA issue. It slowed us down a lot. Just kind of backing off and that, saying, well, we are part of the team, but we're not, the healthcare provider isn't paying us, so we're not that much a part of your team. So anyway, there's kind of like, you know, things to keep your eyes out for. So I will stop talking and see if people have questions for me or for Roxy or for Laurel, and Roxy probably has as much to say about the startup stuff as I do. Thanks.
Let me just encourage everyone to unmute. Vicki, I really appreciate you mentioning that slogan because I recently used it. Can't say where, but I recently used it just this week. Too big to fail. And that is because of the impact that we see, right? For what is relatively very small investments, what you're looking at, financing MLP, using those funds that are directly from the healthcare provider, adding skin in the game, whether it's operational or through their Section 330 grants or anything else on the healthcare side, even reimbursement, as low as it is, especially in the spaces Dr. Patchen mentioned. I think it's really important for us to understand that for these relatively small investments, you get major returns, right? But then how do you talk about it? So can I encourage everyone to unmute and let us know, a little bit more about what you're seeing in terms of successes, challenges, resources, methods, techniques that the Georgetown team may have already been through in their journey or help us think more about.
Yeah, it also actually just reminded me too, Bethany, on the research side, the other thing I would do is encourage you to think not just quantitatively, but qualitatively. So I am not a research and evaluation expert. Getting that expertise from our university made all the difference. And she is the one who really introduced me to this idea of qualitative, which can include surveying and having conversations and interviewing your patients and clients kind of after, or however you're going to do that. But it's an area that I wasn't familiar with. Lauren, yeah.
Sure. Could I make a comment, maybe ask a question about others' experiences? We, as our MLP is housed in the NICU. It's beyond the pilot stages. And we've done a lot of hospital-wide education about MLP, and there's a big ask amongst the providers to extend these services, and that has always been our goal. We haven't had trouble funding the attorneys, as you mentioned, but we really are, in order to expand thoughtfully, we need more attorney FTE, but we really need that educational support and the research support also to, I think, for sustainability and to kind of justify the hospital's ongoing investment in this work, because, for a lot of MLPs, the health system investment is the most stable. It's really hard to go from grant to grant. And it's it takes up our clinical time that we need to be giving to our patients. So, and that is our wall, that's our ceiling right now. I just wonder, I think someone mentioned in the chat, partnering with the university for, certain research aspects. I think that's a wonderful idea. But any other tips or tricks in expanding the other, or funding for the other worker bees on the team, like specialists, research analysts, that, and I would also add that we are an academic MLP as well. So any pointers there. One thing I would add, we have a lot of very powerful stories and narratives now, and the hospital is super interested in those stories and sharing. This is not a feel good thing, but sharing those stories with funders and with donors to the hospital. But that doesn't necessarily directly impact or feed our ongoing work. And it's sort of a funny corner to be in, to be asked for that data. It's a form of data. And then, but we're really at a point where we're kind of just barely have our nose above water. We're so busy where we are, and really need some extra help. So anyway, just curious about others' experiences here.
Rebecca, it looks like you maybe have something to add.
Yeah, sure. I just think, we had private foundation funding at one point to do a 3-year research study to evaluate self-reported patient-client health outcomes. And part of that funding was to pay for a statistician, since we're a bunch of lawyers, don't know what to do with all this data. So that was really exciting to get the funding, and it went really well. We had great data and, of course, good outcomes showing that MLP is effective and improves health. And then the other thing is, we have had some medical students actually offer to work with our data further. And NOLA also has worked with those med students. So
That's
I agree though, because I end up wanting to spend my time doing legal services, but I want that to happen because I'm tracking all this, but it's not my area of expertise, and I'm busy being a lawyer. So
Laurel, do you want to talk about kind of some of the research stuff that's going on with PLAW?
Oh, sure. Happy to. We've sort of taken a two-pronged approach. Part of what we're trying to share is just the experience of making attorneys part of the medical team, and how we've done that. And then sharing some of the impact that we've seen at more of a commentary level. The other piece is we have the results from our needs assessment, which guided our initial work, and then also talking about, what kind of legal needs have we identified, what has popped up, what has, been important, and then how long that has happened, or how long those cases go on, et cetera. A piece that I'm very interested in working on with the head of the evaluation for that works with Vicky for Health Justice Alliance is also just provider satisfaction. This has had a tremendously positive impact on provider satisfaction. And so we're looking forward, trying to capture that as well. The work that Roxy's done around employment law has also made it really very apparent that, like in DC, we have frankly really supportive framework for employment law and in pregnancy in terms of what's on paper. But what we've seen is our patients don't experience that. And so also thinking about how to begin to bring our experience of working in this way to more of a policy conversation around what's needed, because we actually in our area have a lot of the laws that we'd like to see, but the accountability piece is not there. And then I think the last area that we've talked about is thinking about what kind of data we need to be collecting in order to ultimately go back to like Medicaid in DC and say, you know, we'd really love to submit you a bill, frankly, for the work that our attorneys are doing, because this is the outcome and this is the result. And that saves you a lot of money, because it does. I mean, I think one of the areas that's had the biggest impact has also been housing security. And all of us as providers have seen it and talked about it, and how like it's almost preventative. We have these patients that we become aware of all this instability with our housing that's increasing. And Roxy's been able to do some incredible work just to sort of stabilize things, and they don't lose their housing as they're about to give birth. And it's been incredibly impactful. So those are the areas that we've been talking about just in terms of how to continue to make the case. And what is it that we need to be offering back to the community in terms of how do you get this buy-in and how do we get things started?
Yeah, thanks, Laurel. And you know, the other thing I would say too, and I think it's just because we're a little bit deeper in time-wise with our cancer project, but I think that there are other markers that we can use to show value to the hospital system that, you know, we didn't necessarily understand until we really got a few years into the project. And so, for example, with the cancer law project, when we first started, within the first few years, it became clear that patients who were part of the medical legal partnership missed way fewer appointments than they were more likely to show up if they also had a legal appointment. And that was something that I know the oncologists got super excited about. And again, I think it goes to that kind of trust and time. And the lawyers, even though we probably should have limits sometime on the amount of time we spend with people, we're not under that, like, you know, every 15 minutes we've got to be in a different room. So I do think that we contribute to patients feeling heard. And I think that that makes a big difference. Really interesting and super exciting and very, very, very preliminary. There seems to be some correlation that we're finding in our cancer patients who get legal services and their willingness to enroll in clinical trials, which is something we had absolutely no expectation about, but just heard from the oncologist who runs that program. He's like, you know, do you know that we're like 2 to 3-fold times as many, and these are all minority patients who have enrolled in cancer trials since they started working with the lawyers. And again, I think that's trust. I think that's you know, you're helping me, so how can I help you, kind of thing. And we're not asking them. We didn't even know that that was a question we could be involved in. So again, I think there's lots of ways you can think about, like, how are we bringing value to the system? It's you know, it's really, really, really hard to show that because Roxy helped someone keep their job, that they didn't have a preterm birth, or, you know, that they eliminated some of that stress. I don't know how you need smarter scientific brains than mine to figure that stuff out. And lawyers are not good researchers, which is why I that was like my number one thing. I got a PhD, you know, she has her thing is maternal health. I'm like, she's been amazing. I also think a lot of us work with really small numbers because, again, you can't see as many. So the other thing I would love to see, and maybe this is something, Bethany, that the National Center can facilitate, but like, could we come up with some kind of a protocol or something that we used across sites so that we could aggregate data that maybe, you know, Robert Wood Johnson would be interested in, or Picori, or somebody like that. I'm super interested in that too.
Yeah. But, you know, I disagree with you, Vicki. I think we are going to find associations with things like preterm birth and low birth weight. I absolutely do.
Absolutely. Yes. No, that's the dream. Laurel's living the dream for sure on that.
We can make it all a reality.
Yes, we would love to see that.
Mm-hmm.
Well, there's plenty of hospitals that don't want to see that too. So, but that's a conversation for another day.
Yeah.
Lauren, do you want to jump in?
Sure. I just, that's so powerful what you said. And I hope we can figure out a way to prove the association. But I have teenage patients tell me all the time directly, if I only had a house, this would not have happened. If I only had, one stable adult, this would not have happened. And this is, pregnancy at 14, which is tied to, preterm and low birth weight babies, and a host of other things. Like it's there. We all see it, on the ground, but how do we prove it with the work that we do? How do we prove that this medicine is the cure?
I hate even jumping in on that, Lauren. I mean, sorry, Roxy, go ahead. That was powerful.
No, it absolutely was. I was just going to say that getting the feedback from the client, which goes back to just those client stories. So we have here at DC the commission, and we're able to testify in front of city council, but they want to hear client testimony or, community residents testimony. And that is something, right? I joke, but I get like a baby tax because our services are free from our patients because they are delivering healthy babies. And so they will send a picture of their healthy baby. I still haven't had anybody name a child after me, but
This is gonna be the year,
That
Roxy.
you know of.
that you know of yet. But I said Roxy or Rocky are very strong names. But we do, but all jokes aside, I think it is just hearing that feedback from patients. And I know Laurel has shared so many stories of patients coming back and saying, oh my gosh, you connected me to, Roxy, or I talked to so-and-so and I feel so much better. And we provide these client quotes because we do provide our data that we send at the end of each month. And we let folks know, we let our partners know exactly this is what the patients are saying. This is what they need. And this is how we were able to serve them. And this is their feedback. Sometimes it's, I didn't feel heard until I talked to you, or because I talked to you now, I did tell the provider, X, or that I didn't want to take this and I asked for an alternative. Where we weren't, just like kind of how Vicki was talking about the cancer law, we didn't ask them to say, request different meds or see if there's an alternative, plan for you. But they got that from what we were saying. You don't need to have your landlord, you don't have to accept the first, a recommendation from your employer or accommodation from your employer if it doesn't actually work for you. And so they take that and they use that in other facets of their life. And then they feel again, that autonomy, that empowerment to be oh, I am a strong advocate for myself. And this is how. And so all of that again, that kind of closing the loop and making sure that the patient, who we are here to serve, feels very much a part of the team as we are, we feel to the healthcare team and how the healthcare team feels to us.
Oops, oh, sorry, Bethany. I was just gonna say, one of the reasons why I think MLPs are part of the way forward for OB is that you see that kind of, cascade effect that Roxy just described with patients. You also see an interesting cascade effect with providers. We start doing our jobs better because we have the partnership that we need to not be afraid of either asking or being honest about what we're observing and seeing that we know needs a response, but one we don't know how to execute or launch. And even with myself, I mean, one of the last times I referred a patient, she was the summer and it was hot and she was third trimester. And man, in reflecting back on it, to be honest, I was like, would I have even done anything with that before other than, be empathetic? But, instead I was like, I'm hooking you, and we resolved it. And she didn't have to be outside in the third trimester getting dehydrated and contracting, so it's providers do better. We're able to be more of who we want to be with this partnership.
Did you just come up with a new slogan for us, Laurel? Be all you can be through MLP? Take that, DOD. as in Department of Defense and US Army.
Bethany, we didn't
yes.
leave you time at the end. We were supposed
No,
to.
but
I'm so sorry.
No, you're okay. I just want to know that's all right. I've been in the chat. I've integrated it into, including new slogans for us, into closing us out. Vicki, if you can, and everyone, just give me a moment to just thank you all, especially for supporting us, not just on the first year where we did maternal and child health together with our friends up at Yale and CCA Connecticut, but also coming back a second year to continue to support this maternal health MLP project. Also, we have some of the folks who joined us on the earlier session. So Nola Booth from Law New York, who joined today, as well as, I'm not sure she had to go, but we had Courtney Mendoza from LA also rejoin us on this. For the cohort, again, you stepped away from your day-to-day work, either serving patients or clients or someone in the community. And I want to thank you all for continuing to invest your time and supporting everyone around the country